Just wait for everybody to come in and then we can get started. We have a great informative evening, lots of good information surrounded by amazing people, patients, doctors, caretakers. It's my honor to be here. My name is Lisa Carberg. I spent my career until here being a newscaster in Connecticut, and I have always done medical reporting as well. So most recently, I worked at WTNH for 7 years, and I was at NBC Connecticut. And so through my medical reporting, I got to interview all of these doctors. I did many stories on brain tumors and research, always fascinated me very much. And so I had the honor of interviewing these doctors and doing stories with them before I got to call them my colleague. I've been here, as I said, 2 months. I'm media relations in the Yale Cancer Center, and I have done stories with some of the patients here, and it's just amazing to have them here with their doctor and having told their story on News 8. So before we get started with the program, I thought I'd like to tell you, you probably know a lot of these doctors, but I just want to make sure, I want to tell you a little bit about each one of them and their background before we get started really quick. Ranjit Bindra, Harvey and Kate Cushing, Professor of Therapeutic Radiology and Professor of Pathology, Vice Chair for Translational Research and Faculty Development, Therapeutic Radiology, Co-Director of the Chenevert Family Brain Tumor Center and Yale Cancer Center co-leader. Dr. Sylvia Kurz is Associate Professor of Neurology, Neuro-Oncology, Co-Director of the Chenevert Family Brain Tumor Center. And you'll be hearing from each one of these. And Dr. Jennifer Moliterno, Professor of Neurosurgery, Chief Neurosurgical Oncology, Co-Director of the Chenevert Brain Tumor Center, Director Susan Barris, MD, Neurological Oncology Program, Surgical Director, Facial Pain and Spasm Program Director, Neurosurgical Oncology. And in my reporting, I learned that Dr. Moliterno does the most brain tumor surgeries in Connecticut. So we've got the best right before us, and consider yourselves very fortunate. We also have with the Connecticut Brain Tumor Alliance, and if you're not already involved with that, you should. It's a wonderful advocacy group. I've emceed some of their events and gotten to know a lot of people through them. And you'll also hear from Chris Cusano. He's the CEO. He went from being a lawyer to being an advocate. So he's a pretty special person here, and he's put together an amazing. Also, Nicholas Moore, Dr. Nicholas Moore, Assistant Professor of Therapeutic Radiology, and Dr. Nicholas Blondin, Associate Professor, Neuro-Oncology, Clinical Research Team Leader, Medical Oncology. So doctors, I let you get the program started now, and thank you for letting me welcome you. It's an honor to be here with you tonight. Thank you.
Hi, good evening. It's so great to see everybody. So many familiar faces. I'm sorry I'm in scrubs, but I came from the OR. So there you go. All right. We just continue? Yeah, we just continue. So I'm Jen Moliterno, as I was introduced, and I am a brain tumor surgeon. And I know many of you for that reason, and even for the ones I don't. I hope to talk a little bit about what precision brain tumor surgery means and what patients need to know. Someone had asked me specifically to focus on how to choose a neurosurgeon and how to see what's important. And I can talk a little bit about that, of course, understanding that maybe a lot of you have had surgery or know people who have had surgery, but I think it's always useful to know, and then maybe for the next person who might come to you and ask. So I have two disclosures that aren't relevant. I first wanted to mention Dr. Susan Barris. So years ago, before COVID, we would do this type of symposium in her name and in her honor. She was a pediatrician on the western border of Connecticut, and she had a big seizure in her practice. And then came to find that she had a glioblastoma located in her motor strip. She was a really avid marathon runner and really health fanatic. And she was in her 50s when she was diagnosed. It's now 7 years later, and she is still alive and thriving and doing well. And Dr. Susie, as my son calls her, and when we text with her, and she's a character. And what she had said to me guess it was a few years after she was diagnosed, she said, I have never been all that philanthropic in my life, but having a brain tumor changes your perspective. And so she very graciously and generously donated quite a bit of funds to our program in support of our work and our efforts. And she's just really wonderful. So I just wanted to acknowledge her and thank her, because a lot of what we do is because of her. And a lot of the reason why she's here is because of Dr. Blondin, who has taken excellent care of her. So we are the premier academic neurosurgical oncology program in Connecticut, highest volume of brain tumor patients and surgeries. And we're really fortunate for that, and fortunate that patients come from afar to seek our expertise. I can speak for all of us who are the clinicians in the first couple of rows that it's really our privilege and our honor to take care of you and your loved ones and anybody who seeks our care. As such, our surgical practice and, of course, our oncology and radiation practices are those of really complex tumors. And so a lot of times they're referred to us from other neurosurgeons, like the one I did today and a couple of the ones that I'm going to do tomorrow. Gliomas in more eloquent cortex, or large tumors on the brainstem, more aggressive types of brain tumors, or deeply located tumors. What's unique, I think, also about our program is that all of our tumors undergo whole exome sequencing, which is something called next generation sequencing, which I think we'll touch on a little bit, and the impact of that in treatment. But what's important about that is that we meet and discuss as a group, a multidisciplinary group, which is really important to everyone's care. And then we can really target and treat the tumors on a more precise or personalized basis. So for me, this was actually a slide I put together for a talk I gave about a month ago. It's just a little bit of my practice, and it's a busy practice, and it has continued to be. So for primary brain tumors, those are tumors that originate in the brain versus elsewhere in the body. Either in the brain or along the various nerves, or covering of the brain or the skull base, et cetera. That's what we're talking about when we say primary brain tumor. It's important to have surgery, so either a biopsy or removing the tumor, and we can talk about that a little bit more, but it's important to establish the diagnosis. I always say that we're all really good at guessing what these tumors are, particularly in certain locations, but we never know 100% until we actually have that piece of tissue. And now we don't talk about the tumors really in terms of a glioma or a meningioma. We talk really in terms of the molecular makeup and the mutational profile of them, and that's really important. The goal is always to remove as much tumor as safely as possible. There's a couple of exceptions to this, lymphoma being one. But it really is important to remove as much tumor as safely as possible, and safely being the key word. And there's things that we can do to make it safer. It helps decrease the tumor burden, helps provide symptomatic relief, and really, without getting into too much technical aspects, it has shown overall and progression-free survival. And so it impacts people's lives, impacts people's quality of lives, and there's a big reason and proponent to do that. So preparing, I think, for a brain tumor surgery, I can't even imagine what it's like to be diagnosed with a brain tumor and then to be told that you have to have brain surgery, like how scary and daunting that is. And so we appreciate that and understand as much as we possibly can, but we get that. So what I always tell patients, and it's really, really true, and I think this applies if you've already had your surgery and you're in recovery or in adjuvant therapy, et cetera, people with brain tumors are a lot sicker than they look. It is always amazing to me, the people who are sitting across from me, and how normal they look when I know what's inside their head. It's incredible. And the brain can really compensate well until it can't compensate. And you don't really know that or appreciate that, but trust us when we say that we do know that. It can really be harder for some patients to go through surgery than others. And so when the brain has been damaged by the tumor, or certain structures in the brain have been damaged, it's hard for patients to just bounce back. It's hard for older patients to just bounce back. And so I would say the one thing to keep in mind as much as you can is to give yourself some slack, because it's not always easy. It's most of the times not easy at all. And again, the key here is that the tumor has really injured the brain and the structures around it. And so probably the worst part of my job is that I see the effects that the tumor has done after I remove it. And so that's a very hard thing for me to get used to, and also to try to convey. This is an example of various patients from my practice. So the upper left is a large meningioma at the base of the brain, which is up against the medulla. The medulla is part of the brainstem that's like important to live and breathe and your heart and stuff like that. That was where I was operating today. And that person was totally normal, right? And so there's swallowing nerves that are there. There's a lot of stuff in that area, really a high price real estate. And then that's after surgery. This is a patient right side because it's flipped on everybody. This is like pretty much the whole frontal lobe filled with tumor. And this patient walked in totally normal as well. This one here, I mean, you cannot miss that. Really large, nasty. It turned out to be a glioblastoma, and it's putting some mass effect on what we call the ventricular system. That person walked in normal as well. And then here, this is another tumor that's on the brainstem, a vestibular schwannoma. And where the line of the brainstem is supposed to be straight like that, you can see how indented. And really, the brainstem, this is the nose, which is midline, is being pushed and shifted to the other side. And that's the post-op scan. And so I can tell you, I don't remember off the top of my head, to be totally honest, because I do so much. But I can guarantee that everybody in this picture, they have beautiful post-op scans. Well, actually, I forgot to put the post-op for that one. I'm sorry. But I removed it. I'm sure to some degree they were very sick after surgery, right? And even a little bit after surgery. And so it takes time to recover because look at these massive things and what we put patients through to get them better. How to choose a neurosurgeon, I can't stress it enough. It's like anything else in life. The more you do, the better you are. It's like anything else. And so I operate all over the brain in all the various compartments, but it's still doing it every single day, which is what I do. It's just like any other task. When you do something, the more you do, the better you are. So experience and volume matters. Don't be afraid to ask questions. Don't let anyone talk you into surgery. So I can't tell you how many times I reoperate on patients because they were sucked into a surgery in an outside hospital that really it was not within their wheelhouse of what they can do, and they did a lesser surgery. And it can always be more challenging to have to reoperate on patients. One of the cases I'm doing tomorrow is that as well. So just make sure, because there's, usually in most circumstances, no need to rush where it's not life-threatening. So it's really important to kind of take a minute, know who you're working with, know who you're dealing with, know about the institution and the infrastructure and that sort of thing. I always say that people who promise too much, I'd always be leery about that because that's just not the reality, at least of complex brain tumor surgeries. Ask around. The CTBTA is an enormous resource, which I'm sure most of you in this room know, but they're really helpful at any stage of your diagnosis. And what's the plan after surgery? I always say that it doesn't just stop with me. It's Dr. Kurz, Dr. Blondin, Dr. Bindra, Dr. Barden. It's everybody else. It's the multidisciplinary team that's important. And also, it's always good to get other opinions, of course, especially if maybe starting in a community hospital asking for an academic institution, but don't get bogged down in too many because then you really delay care. And this was a little figure that the chair of MGH had given me, which just shows basically mortality among surgeons when they're performing cranial tumor surgeon. And it's remarkable because it, again, shows the more that you do, the higher volume, the better the patients do. And so what we offer, what is needed, this is just to run through really quickly, subspecialized expertise. So all I do is brain tumor surgery. I don't do spine surgery. I don't do other type of surgery. I just do brain tumor surgery. That makes a difference. Functional MRI, so we understand the function of the brain. The neuronavigation, which is a GPS system. That's a very basic thing to have, but that's really important. ultrasound. This is an ultrasound and me ultrasounding the tumor in the operating room. This big white thing is the tumor, and the little black thing is the carotid artery in the middle of it. So that's an important relationship to know. Intraoperative MRI, we're the only hospital in the state that has a 3 Tesla MRI. So the same MRI in the community, when you go to get an MRI is actually in our operating room. We have intraoperative angio suite, so we can embolize tumors if we need to with our endovascular colleagues, neurophysiology, functional mapping. So this is the more sophisticated surgical techniques, awake surgery, which I'll touch upon, advanced microsurgery and approaches, and then again, recognizing and realizing that it doesn't just stop at surgery. We need to understand the biology of the tumor and then the next treatments. So a few examples. This was a patient who presented to an outside hospital back, I forget what year, to be honest, but in December of a year, several years ago. And so had some language problems, and this tumor that you can see here, again, it's flipped, so it's a tumor that looks like a GBM, and it's near the language area. Nick, this was your patient. And so he underwent a biopsy, as you can see, a few days later. This is the post-op scan. This is then the post-op MRI. You don't have to be a brain surgeon to realize that the post-op MRI, that tumor right here, looks very similar to the preoperative scan, right? So there was really nothing done with surgery and no tumor removed. So thankfully, he was referred to us. We ended up understanding that anatomy and relationship with this fancy functional MRI, and we were able to gross totally resect him, which improved his language and then also gave him survival benefit. So again, you might say, how does this happen? Brain surgery is hard stuff, and doing a good job at brain surgery is hard stuff, and that's why you really have to make sure you have the right people and surrounded by the right people. This is another gentleman who went to an academic center in the state and underwent a biopsy, subtotal resection. As you can see here, this was in the motor area. And then I was called that he was worsening in terms of his strength, and he could not move his left side and specifically was having trouble walking. So we were able to get another one of these fancy MRIs and then did some what we call motor mapping, which is beyond this talk. And you can see we gross totally resected his tumor and his strength improved, and he's now returned back to work. This is another example of a patient who was seen at an outside hospital. This is a big meningioma that's kind of right behind the eyes, as you can see the nose right here. So this patient was seen elsewhere in 2013 and was told just watch it. In 2019, she had some repeat imaging, and you can start to see the black in the brain, which is a lot of edema and swelling, and she started to have some cognitive changes, behavioral changes, etc. They said to continue to watch it. This is when she presented to me 5 years later, now with intractable epilepsy and an altered mental status. And so here's this enormous tumor. And because the tumor became so big, it changed the flow dynamics. So she developed an aneurysm on the artery that was right behind the tumor. So we ended up getting an angiogram on her. The endovascular neurosurgeon tried to put some coils to protect the aneurysm before I took the tumor out, but every time he did, she lost the strength in her legs. So that was not safe to do. So I ended up taking her, and in just a couple of hours, I was able to resect the tumor and also clip the aneurysm. The best part of that is my husband is a vascular neurosurgeon who clips aneurysms. So from that day on, I went around telling everyone I was a vascular neurosurgeon. And so if only I could show the video, that would be even better. This was another patient who in 2003 had this scan. This is a very unique tumor. It's an epidermoid cyst, but it's really a tumor, not a cyst, in the middle of the brain. And you can see that these are the ventricles that house the spinal fluid that are really big. Another neurosurgeon, actually 2 neurosurgeons, took him to surgery in 2004. This is after he had 2 surgeries and a shunt at another hospital and was in rehab for years following that. He finally recovered, but as you can see, there's still some tumor that remains. In 2021, he ended up having radiosurgery. It grew, it continued to grow, and then he was finally referred to me. This was the original scan, and then this is where we gross totally resected, and he was home this time on post-op day 2. So a very different course than what he had previously. This was another patient I shared with Dr. Blondin, a patient who was seen at another hospital, had this really large tumor in his fourth ventricle, again, up against the brainstem. Another neurosurgeon had biopsied it, put a shunt in to help deal with the fluid, ended up failing the shunt and failing everything because the tumor was growing. And we gross totally resected him. He had a long recovery, of course, given the location of where the tumor was, but at least he was disease-free and then improved back to normal. And then this is another brief example of a patient who underwent a surgery in May for an acoustic neuroma. And then basically, again, the post-op looks very similar to the pre-op. The tumor's right here, post-op tumor's right there. Ended up being referred to radiosurgery because that's a non-invasive procedure or less invasive procedure, except that there was a bunch of swelling in the brainstem, was on steroids because of that, started to develop muscle weakness because of that, had all these side effects, and then finally referred to me here, and then gross totally resected. Had some facial weakness that actually improved after surgery. And then finally, a patient who underwent a subtotal resection by another neurosurgeon for a meningioma was referred to us actually for radiation with this residual tumor. And so here at Yale, I was mentioning that special sequencing that we do. And so it was a grade 1 tumor, which is thought to be a benign meningioma. But when we looked at all these mutations, and these specifically down here, we were concerned that this was more atypical and had a higher risk of progression of disease. So we ended up getting a venogram, which showed that the tumor had occluded this big vein that's back here, and then we took her back to gross totally resector, and then she went on to have radiation. Instead of radiating up front, we were able to save the radiation and then resect more completely, and she was intact. So again, just emphasizing the precision multidisciplinary brain tumor treatment program that we have here. It's important to have a good surgery, it's important to have a good surgeon, but it's just as important to have a good team, and it does not stop with surgery. And so I think the take-homes are, especially after surgery, focus on recovery. The rest will come. You have to recover before you move forward. So many people are always like, when do we start the next steps? You have to recover, and you have to focus on the recovery, and sometimes that can take long. Good nutrition is really good. We offer support groups. Stefania does an incredible job with that, and with the CTPTA, we have dinners for that, so please join us there. Take one step at a time. Believe me, that's the hardest thing to do. Trust the process, also the hardest thing to do. And just understand things can get worse before they get better, but they will get better. And we are here for you. We understand it's scary, and don't settle for less. So that's it. With that, Dr. Kurz is going to come up and talk about next steps.
We do. I want to maybe say, did we say we wanted to do questions in between the talks? Anyone has any urgent questions? Otherwise, yes.
Yeah, I had mentioned it, but quickly.
I'm sorry.
It's okay. Functional MRI is, it looks at the function of the brain. So basically, it shows us where the language area is. It shows us where the motor area is, stuff like that. So for instance, the surgery I'm going to do tomorrow, one of them is going to be an awake surgery. So she had a functional MRI, which shows where the language is relative to the tumor. So when I keep her awake during surgery, I know where language is, and I can stay away from it and then confirm it. The eye MRI is the intraoperative MRI. So it's the big MRI that's actually in our operating room. Anything else? Of course. Okay.
All right. Thank you, everyone, for being here today and allowing me to speak a little bit about brain tumor treatments. I want to preface this talk by saying this is really a multidisciplinary effort, right? So it's not like only like the chemotherapy, it's like really kind of the combination of surgery, excellent tumor resection, radiation, and then medical therapy, systemic therapies. And, you know, we couldn't do this without the great work from all the support people as well, so social work, and then also the I think the emotional support that patients and families really need. So I just want to kind of get out the statement here, like we're here to help you and connect you. So you're not in this alone. Okay, but now we're going to talk a little bit about how we think about these tumors and how we manage those tumors. There are about like 500 different types of brain tumors, so I'm not going to cover each single one of them. So I'm going to just speak a little bit about the tumors that we most often see and how we do approach them. Before I do speak about the glioblastoma tumor and then IDH mutant gliomas, I want to spend just one slide and 1 minute about, oh, sorry, that didn't work. Sorry. I had a little beautiful microscope in there that didn't kind of carry forward. So I want to kind of speak with you for a minute about what happens between surgery and the actual tumor diagnosis, because oftentimes patients, when they first meet me, they're worried about like, what is it? What is it? What do I have to prepare for? And as Jen just mentioned, it's like trust the process. And for many people, it feels like this waiting game until we finally learn what we're dealing with. And so there are a couple steps in between. So once Dr. Moliterno has taken out the brain tumor, the tissue goes to the lab and our pathologists look at it. Those are also important members of the team. And they do first like some simple staining techniques, and then they look at the tissue under the microscope. And that gives them a first idea of what type of tumor this might look like. And most often that gives them a very good idea of what we're dealing with. So it can give them information about, is this a glioma tumor? Is this more like a medulloblastoma tumor? Is this a lymphoma tumor? And it also can give them an idea of the tumor grade. So is this a grade 2 tumor, a grade 4 tumor? Like how aggressive might this be? So they will have like a good guess at what the final diagnosis may be, and they will share that with us at Tumor Board. And that is the first important step in really treatment planning and moving forward in terms of what things do we have to put in place. In addition, though, the pathologist will order all these different types of tests, and some of them are available, or the results are available within days and weeks. And while they may not kind of steer treatment decisions in a big trajectory, like they will not kind of make a decision about like, are we going to do radiation or not do radiation? But they will better characterize those tumors for us. And for example, the IDH mutation that we'll hear about a little later, this is a result, or some of the IDH mutations can be discovered in that first set of molecular tests that we do. And in a way, this is fine-tuning the diagnosis. Occasionally, it can also change the tumor grading, and therefore is really important information to gather. But that information is still available within a reasonable amount of time and will not hinder us from really getting a good treatment plan together for you. And then Dr. Moliterno mentioned it already. We do this whole exome sequencing here. That gives us a real thorough fine print analysis of the tumor and really characterizes this tumor really well. And while it may not be available to make that first line treatment decision, it is invaluable information to have to really inform you about what this tumor actually is, what the prognosis might look like, and then also, if needed, can inform treatment decisions down the line. But the downside of that information is that it takes a little longer to come back. So I do want to say it's okay for this to take a little longer. We do want that information as soon as possible, but it doesn't impact the treatment decisions upfront in a big way. Just want to say this here. Okay. And then, so this is a summary. Like we do classify CNS tumors based on the WHO classification. Every couple of years, there's a new edition of the WHO classification. So most recently, it was issued in 2021. We're expecting another classification to come out perhaps next year. And here, I just want to say, as I mentioned, like there are 500 different brain tumors. They're all classified in this huge book that comes out. But these molecular results that we get back from all these various studies that the pathologists do for us, and the genetics department, they characterize the tumors for us. So this table just shows you all the various types of gliomas that we recognize today, and the various genes and molecular profiles that are altered in these different types of gliomas. And for the remainder of this talk, I'm going to focus on those tumors that I highlighted here. So those are the high-grade glioblastoma tumors that are typically IDH wild type. And then there are the IDH mutant tumors that come in two flavors. One is the oligodendroglioma type, and the other one is the astrocytoma type. And then I'm going to touch on the type of tumor that's called a diffuse midline glioma that are characterized by H3K27M alterations. Okay, so to speak about glioblastoma. So glioblastoma is the most common malignant primary brain tumor that we see. Primary brain tumor means that the tumor starts out within the brain itself. It's not metastasizing to the brain from other parts of the body. It's the most common tumor, and each year in the US, there are about 12,000 new patients diagnosed. The average age of onset is in the 5th and 6th decade of life, but we do see patients who are younger than that and then also older. The current standard of care therapy that I will speak a little bit more about is maximum safe resection followed by radiation combined with chemotherapy, and then followed by chemotherapy for monthly cycles for a total of 6 cycles. And then so to speak a little bit about what glioblastomas and other brain tumors can give for symptoms, as you probably all have learned by now, is that the brain is a unique organ, and that different parts of the brain govern certain functions of the body. And depending on where the brain tumor is located, the signs and symptoms that brain tumor can show can vary. So headaches are common symptoms. When there is a bigger mass inside the head, there can be changes in pressure inside the head that can lead to nausea and vomiting and other symptoms related to the pressure inside the head. Seizures can be common. And then there are other symptoms that are based on tumor locations. So frontal lobe located tumors may come with increased fatigue, concentration issues, personality changes. Temporal lobe tumors can come with language problems, memory problems, seizures. Parietal lobe tumors can present with sensory changes, and occipital lobe tumors can present with vision symptoms. The first step, what we always do in the emergency departments, is a CAT scan followed by an MRI scan, and characteristically, the glioblastoma tumor shows up as a tumor, like a mass lesion inside the head that picks up the contrast agent in a specific way. So we call it heterogeneously enhancing or rim enhancing, like you see on this MRI picture. And often they are characterized by huge amounts of edema and swelling around the tumor. So the first line therapy, meaning the best established standard of care therapy that we can offer to glioblastoma patients, is maximum safe resection as the very first step. That is important because it does establish and confirm the diagnosis. So also, as Dr. Moliterno said, we cannot be sure of what this tumor diagnosis is until we have seen the tissue under the microscope. And the extent of resection impacts how well patients do. So maximum safe resection, meaning safe, we do not want to take away any function from the patient, but we do want to get as much out as possible safely. And then in addition, because of the molecular and the pathological evaluation that follows, there are important molecular markers that tell us about prognosis. MGMT is one of them, but there are other factors that play a role here. In addition, there may be molecular aberrations that open the door for targeted therapy options at time of recurrence. And then following that maximum safe resection, we do offer glioblastoma patients radiation combined with temozolomide, and then 6 cycles of monthly temozolomide after that. The 2 curves that you see on the right-hand side are so-called Kaplan-Meier curves. So this is out of that original publication that showed that adding the chemotherapy to the radiation means that patients do live longer and take longer until the tumor progresses. So that is the reason why we do this combination treatment. And so now I want to speak a little bit about a few of those high-grade glioma patients that can derive benefit from targeted therapy options. We will offer them as second-line therapy options because that's how the FDA has approved them for. And they're all targeted therapies, meaning the tumor has to demonstrate to us that a certain aberration is present. And if that certain aberration is present, then there is like a matching treatment that we can offer to those patients. That also means that these drugs that I'm going to speak about now are not available to everyone with a glioblastoma, but just the subgroups where we have the right mutation present. So the first one I want to mention is there are tumors that harbor the BRAF V600E mutation, and that can be targeted with the so-called BRAF MEK inhibitor therapy. This is based on the so-called WAR study that was published a few years ago. And on the diagram on the left side, you can see there were bunch of different types of gliomas included in the study, and there were high-grade gliomas in there as well as low-grade gliomas. All of them had in common that they had this BRAF V600E mutation. And those patients were offered treatment in a so-called basket study. It was a relatively small number, 45 patients, and all of them had at least a prior round of treatments. And then the tumor progressed, and they were started on treatment with the dabrafenib, trametinib. And it's important to know that in these tumors where we really rarely see a regression of the disease, in the high-grade gliomas, there was an objective response seen, meaning shrinkage of the tumor seen in 1/3 of patients. And also in the low-grade glioma category, we saw some shrinkage of tumors in about 2/3 of patients. So that is like a huge success in our field. And therefore, the FDA granted FDA approval for recurrent high-grade gliomas with the BRAF V600E mutation. And then another success story from the recent past is that there are these so-called midline gliomas that lie in the thalamus, in the midbrain, in the brainstem, and also in the spinal cord that can be treated with a targeted agent called ONC201. The brand name is Modeso. And so there was this publication where they pulled the data from 5 completed clinical trials that included a total of 374 patients. And those were adult patients and pediatric patients. All of those patients also had at least one prior line of therapy, and then were offered ONC201 as a treatment. That is taken like as an oral medication once a week. And here also they have seen significant response rates in about 1/3 of patients. And this was accompanied by improvement in clinical symptoms. So patients actually did see improvement in their symptoms while they were on treatment. The treatment is really well tolerated with little side effects. The only caveat that was noted here is that patients had to be on treatment for quite some time. So they had to be on treatments for about 8 months before one could see the regression on the scans and one could really experience the improvement in symptoms. And we don't want to stop there. So we're not finished with getting better at working on better treatments for glioblastoma patients. So I'm just highlighting 2 clinical trials that we currently do for glioblastoma patients here at Yale. And one is the GBM Agile trial. This is really kind of the one globally available clinical trial that's available not only here at Yale, but really all over the globe. It's a multi-arm clinical trial. Patients are randomized, but it's not a placebo-controlled clinical trial. So patients and investigators will know what patients are getting. And this is available to patients with newly diagnosed glioblastomas at time when we find out about the disease, or at time of first and second glioblastoma recurrence. So there is one control arm. So in this control arm, patients do not get less than the standard of care. But the interesting and great thing about this clinical trial is that there are these never-ending treatment arms added to the overall program. And at any given time points, we do not only offer like the control arm, but patients can also be randomized in like an experimental treatment arm A, B, C, and D. And each of these treatment arms by itself represents a clinical study. And once completed, once the results are read out, that treatment arm is removed from the overall clinical trial, and then a new arm gets added on to this clinical trial outlay. And currently, these are the open arms. So for newly diagnosed GBM patients, we have the standard of care arm available, and then we have 4 investigational treatment arms. So there are various agents ranging from oral medication that you take every day, IV medications, intramuscular injections that occur once a week. And in the newly diagnosed setting, those are combined with the standard of care therapy, meaning patients do get radiation and a temozolomide chemotherapy, and then in addition, they do get the investigational agent because we do take great care that patients do not get less than the standard of care treatment. In the recurrent disease setting for glioblastoma, the standard of care therapy is a chemotherapy called CCNU, and that serves as the comparator in the recurrent disease stage. And then some of those treatments that are already mentioned and are available for newly diagnosed glioblastoma are also offered for recurrent disease patients as part of this clinical trial. And then there is this drug tinostamostine that is similar to the lomustine drug or the temozolomide drug. That is a new treatment arm that is being added to this clinical trial right now. For each of those clinical trials, the study is planning to accrue 150 patients. So there is like turnover and like clinical trial arms are graduating and new arms are added, but still it's like a robust number of patients that can be added for each of those treatment arms to really deliver valuable information about whether this treatment is working or not. And then I want to mention another clinical trial that we do right now. A lot of patients still ask me a lot about immunotherapy and what's available in the immunotherapy realm for high-grade gliomas or glioblastomas. And to be very honest, like, you know, it has become a little bit more quiet in the immunotherapy sphere for glioblastomas, but there are a few things that are still offered. This is a study that's offered through the Alliance Clinical Trial Consortium. It's also a multi-center clinical trial, and it is focused on the immune tumor microenvironment in glioblastoma, and there seems to be some evidence that LAG-3 plays a role in there. So in this clinical trial, we target LAG-3 and PD-1 with a dual combination immunotherapy treatment. It is a randomized clinical trial, but also not placebo controlled, meaning that patients cannot choose what treatment arm they're getting into, but they will know what they're randomized and assigned to. And in the comparator treatment arm, patients do get like the standard of care therapy, which is the CCNU. And now I'm going to switch to the diffuse glioma category. So those are not high. There can be grade 2 and 3 gliomas. They're most often characterized by an IDH mutation. They're more rare than the glioblastomas. There are about 5,000 patients diagnosed in the United States each year. Typically, the age at diagnosis is younger than the age at diagnosis is younger compared to the glioblastoma patients. So patients may be in their 20s, 30s, 40s. Sometimes they're younger than that, and they can also be older than that. But typically, they're younger than the glioblastoma patients. As I mentioned, the vast majority of these tumors is characterized by an IDH mutation, and we do recognize a few IDH mutations. So there are IDH1 mutations and IDH2 mutations. All of them have the same, implication on the tumor and the biological behavior of those tumors. And then about 1/3 of these IDH mutant gliomas also have an alteration in 1p19q. We call this 1p19q codeletion. And those are the oligodendroglioma IDH mutant type. And then the other non-codeleted IDH mutant tumors are the astrocytomas. A majority of those tumors have an MGMT methylation. For those patients, the best established standard of care therapy now, based on recent studies, depends a little bit. So the first step still is resection, and we do want the maximum safe resection here as well. But for those patients who have like lower risk factors, they're now offered a drug called vorasidenib. For those where there are high risk features, we still consider radiation combined with chemotherapy as the mainstay of therapy. Yes, okay, so that's a duplicate. So the maximum safe resection is important. So similar to the glioblastoma, it does help establish and confirm the diagnosis. Extent of resection here is important as well, and it gives insight into these important molecular markers. As I just mentioned, so we do, in those patients, do a high versus low risk assessment. So one of it is tumor grade. So a grade 3 tumor, we wouldn't offer vorasidenib to. So there is always like radiation and chemotherapy important as the first step of treatment. Extent of resection. So for those who are considered gross totally resected, we are more easily recommending vorasidenib for those. Those with subtotal resection, we have to kind of look at other risk factors, but there we may consider like radiation as the best line of therapy. And then we do also look at the preoperative MRI scan. So if there is enhancement in these tumors present, and the majority of those tumors may not have enhancement present, but if there is enhancement in these tumors, that can be a sign of a higher grade morphology, even if the pathology doesn't really show that. So for those patients, we are a little bit more worried that this is a more aggressive type of tumor. Tumor growth rate, in some patients, we have the opportunity to kind of look at how this tumor has evolved prior to that first surgery. And depending on how slow this has been evolving or how fast it has grown, may give us insight into the clinical behavior of those tumors. So that is another important piece of information. And then how much the patient is affected, of course, also plays a big role in their treatment decision. So for the lower risk patients, where all those factors seem to kind of suggest like a slower growing, lower grade tumor, vorasidenib is truly an option. For those where high risk features may be present, radiation and chemotherapy has to be considered. And so speaking about the vorasidenib, this was a huge breakthrough for our field, led to kind of plenary sessions at ASCO 2 years ago, and was really kind of a huge achievement. So vorasidenib is an IDH inhibitor. It targets both the IDH1 mutations as well as the IDH2 mutations. Other IDH inhibitors are limited by targeting only IDH1, but this inhibitor does target both of IDH1 and IDH2 mutation. In a way, it does slow and halt the growth of IDH mutant tumor cells. And in this clinical trial that we were all excited about, patients with like low risk features after their initial diagnosis, or who had experienced like a progression of disease by looking at their MRI scans a year after diagnosis, within a year after diagnosis, they were offered either vorasidenib therapy or observation, so no therapy. And as you can see on those two Kaplan-Meier curves that I'm showing you there, the red line is the vorasidenib arm, and the time until the next intervention was necessary, so the next surgery or the next radiation or the next line of therapy, was much longer on average in those patients who were offered vorasidenib compared to those who just had observation. So for that reason, the FDA also approved vorasidenib, and this is now available as a standard of care therapy option for patients with IDH mutant low-grade gliomas. For patients with higher grade features or just like grade 3 tumors, we still recommend radiation and chemotherapy. So what I'm showing you here are the results of a study called RTOG 9802 that was conducted through another clinical trial consortium. And here, the researchers evaluated whether radiation compared with radiation plus the chemotherapy combination of PCV is better. And that study established that the combination of radiation and chemotherapy extends overall survival, but also progression-free survival. And that has been the standard of care for all grade 2 and grade 3 gliomas until the arrival of vorasidenib a few years ago. And then other studies have shown that the PCV chemotherapy combination may be more favorable for the oligodendroglioma subtype. And then the temozolomide chemotherapy that we also use for glioblastomas may be better for the astrocytoma type. Now, what of those chemotherapy regimens is offered to you or your loved ones does depend on a lot of factors. So I don't want to kind of appear like we're always only doing PCV for oligodendrogliomas. We always only do temozolomide for astrocytomas. These are individual discussions that patients and their physicians have to have, and we do want to make those decisions on a case-by-case basis. Okay. And then just one word on clinical trials for IDH mutant glioma. So this is, so the vorasidenib is only approved for grade 2 IDH mutant gliomas. But of course, the field and patients are asking the questions, well, could it be helpful for my grade 4 IDH mutant glioma or my grade 3 IDH mutant glioma? And the vorasidenib studies, they're forthcoming. They're not available right now as of yet, but there will be future clinical trials that look at vorasidenib for those indications. But currently, we do have a phase 3 study that's evaluating another IDH inhibitor called safusidenib. And as I mentioned, the vorasidenib is targeting both IDH1 and IDH2, but the safusidenib is only targeting IDH1. But this is currently available for patients with grade 2, grade 3, or grade 4 IDH mutant astrocytomas. And here, this is not started up front after diagnosis or at the time of start of radiation and chemotherapy. Instead, patients do complete their first-line treatments with radiation and chemotherapy. And then once they're completed, their adjuvant phase of chemotherapy, their patients are being asked whether they want to participate in this clinical trial and then can participate and get that safusidenib drug, which is also oral, as part of this clinical trial. This is also a randomized trial, so it's important that we have these control arms. So here, patients will not know what they're taking. So they're either taking the actual safusidenib drug or they will get like a placebo pill instead. But yes, so we are overall, like in our experience, this is also a drug that overall has been well tolerated, and we're excited to offer something to patients that are not candidates for vorasidenib, and we hope that the IDH inhibition in those patients will add to the effects of radiation and chemotherapy. Okay, and then I wanted to kind of mention that this particular clinical trial currently is only available for astrocytomas, but in oligodendroglioma cohort is expected to open soon. And this one I have already said, so vorasidenib studies for grade 3 and grade 4 tumors are forthcoming. And then I want to kind of just speak one word about the so-called AYA tumors. This is like an evolving field in neuro-oncology, and it really kind of is evolving around like classifications and definitions. But I just want to kind of put that out there. So we do recognize that these tumors don't, they're not talking about adult tumors or pediatric tumors just because someone turns 18 or 21 years of age. So there are these tumors that happen in young adults, but can also happen in older children. And they're now kind of coined the adolescent young adult tumors. And the age range is defined as between 15 years of age and 40 years of age. And on the left-hand side, that graph does show you it's also a mixed bag of tumors, what can happen in that space. So there are glioma-type tumors, but then there are also ependymal tumors, germ cell tumors, medulloblastomas. And then just kind of zooming into the glioma tumors, there are various subtypes that we can particularly often see in these AYA patients. And while some of them are characterized by IDH mutations, not all of them are definitely are characteristically IDH mutant tumors. We can see molecular and true glioblastoma tumors in those patients. And then there are these histone mutant high-grade glioma patients that are also touched on. So those are these H3K27M mutant tumors that we have this Modeso drug available for. And then there is this other group of patients that have important alterations in the RAS MAP kinase pathways that I think are still kind of telling us their stories, and we're still learning a lot about these tumors, and hopefully we'll learn and develop better treatment options against all these molecular alterations that we can see in these tumors. Okay. All right, to sum this up, we talked a lot about glioblastoma, which is the most common primary brain tumor. The standard of care therapy involves multimodality therapy consisting of maximum safe resection followed by radiation and chemotherapy. And we have, in a few select cases, target therapy options available that we can offer to patients at time of recurrence. In terms of the diffuse glioma category that are often IDH mutant, the treatment choice after maximum safe resection is really driven by clinical risk factors and molecular pathological risk factors. Some of those patients qualify for treatment with IDH inhibition with vorasidenib. Others require radiation chemotherapy. And here there are ongoing clinical trials aiming at the IDH mutation. And then for a lot of other tumors that happen inside the brain, there is intense research ongoing, and we do continue to learn about all these tumors, and that information will help us develop better treatment options. Okay, and then lastly, I want to say this does take a village. So there are a lot of people involved in every patient's care, and you know, I'm naming like the neuro-oncology teams and the radiation oncology, neurosurgery teams here at Yale. But then also like all the support staff. I want to show that to the CT Brain Tumor Alliance, who is strongly represented here. I'm sorry, I just mentioned Chris Cusano on this slide. I know you're kind of really a strong group. And I think these are, the shot I want to make is that there are really caregivers, patients who have a vast knowledge base with how to care for brain tumors, and we do want to connect you to the CT Brain Tumor Alliance, where you find like helpful resources, how to deal with this new diagnosis that kind of sets your life upside down. And yeah, I hope that at the panel discussion that we have a little bit later, that really can get into that spirit of asking questions and how to. Okay, with that, thank you very much. And then are we doing the questions later? Okay, so then I'll welcome Nick Moore, our newest addition to the brain tumor family here, who will shed some light on the radiation aspects of things.
Thank you, Dr. Kurtz. Oh, we've got some extra slides here. Okay. I should study these. Okay. So thanks everybody for having me here. It's nice to see so many familiar faces. This is going to be a shorter talk and much less comprehensive than the two master classes we just went through, but hopefully addressing some questions I oftentimes get about protons versus photons. So this is a topic that's in the news. About a year and a half ago, we started building the Connecticut Proton Center in collaboration with Hartford Healthcare. And it's definitely on its way. These are kind of recent photos, courtesy of Dr. Roberts, showing the very nice lobby in Wallingford, some landscaping work, very nice treatment room, which is under development. And then on the bottom right here, we have the really impressive machinery that underlies all this technology. This is a cyclotron. So it's moving along well, I'm told, and first patient is slated to be treated in November. But I oftentimes get the question, when should I get protons, right? What are protons? So I want to take us back to maybe some high school physics, and just address, what is a proton? What is a photon? How are they different? So a proton, as some may remember, is a particle. It's part of the atom. It's one of the subparticles inside the nucleus. And so it has mass, whereas a photon is just sort of a physicsy way of saying light. And one type of photon would be an X-ray. And so when we talk about photon radiation, we're using high energy X-rays. And both of these modalities are used for radiation therapy. Among other methods we won't get into today, but when photons or protons are high energy, they penetrate into tissue and they damage DNA, and this can be used to kill tumor cells. And generally, this is effective, excuse me, because tumors are generally more sensitive to radiation than healthy tissues are. And so modern technology allows us to deliver therapeutic radiation with very high precision. This is one on the bottom left here. I have a ChatGPT generated, mock-up of what it is like to get VMAT, which is pretty accurate. So you have radiation coming in from all angles. The patient is on the treatment table in a face mask. And using modern methods of delivery from all angles, we can create really good beam geometries and get the dose where we want it to go, shape the beams, and have the radiation go where we want it to go and avoid other areas. And so on the right is just an example of what this looks like from like a radiation dose standpoint. So you have different colored lines showing the radiation dose, and you can imagine that blue sort of outline in the on the screen is the target, and we have really good dose fall off going away. So this is a representative example of what photons can do in the modern era. So where do protons come into all this? So the key thing is that protons and photons deposit their energy differently. And this creates some of the unique physical properties around protons that we get excited about in specific situations. So conventional X-rays or photons, you can see on the left, they sort of deposit their dose in tissue as they go along. So they're not immediately at the skin surface, they penetrate a little bit into tissue, they start delivering their energy, and then that sort of falls off. So you can see kind of the tumor in the middle of the screen here. There's dose going where we want it to go, and then there is some exit dose. Whereas protons have this unique property called the Bragg peak, where there's conversely not very much energy that gets deposited at first. As we penetrate further into tissue, we arrive at the sort of designed point where we expect the proton to essentially stop, since it's a particle. So you see that there's this big deposition of dose right into where we aimed it to be, and then there's really nothing after that. So this is where we talk about not having any exit dose from protons. And here's a nice cartoon schematic of kind of explaining that in a different way. Photons are just high energy light passing through. Energy decreases as it goes through the body. Healthy cells, are around this. That's true of protons as well, but you can potentially spare healthy tissue kind of on the way out. Whereas if you use protons, which have a sudden burst of energy and then stop. So this is all really promising, and we're very excited as a field about what this can do for our patients. And it's still early days, and many of the really important studies are underway still, and we're starting to get readouts on some of the trials in different disease sites. But I think what's emerging so far is that protons, despite all these very real physical benefits, when you actually run the studies, don't always have advantages over photons. And so that's kind of a takeaway for all of us that, there are select situations where they make a big difference and others where they don't. So big trials have been run now for prostate cancer and breast cancer, showing very similar outcomes, really good outcomes for both photons and protons. Head and neck cancer, there's been some studies showing really promising outcomes in terms of decreased toxicity and maybe even improved survival with protons versus photons. But there's potentially some debate going on in these studies in just the last few months. There's been other recent trials that have not shown that kind of difference. So bottom line is there are advantages to be sure, but we are still waiting for evidence in specific cases where we can sort of say, oh, protons really make a big difference. This is definitely the way to go. And we need to do more research and wait for the results of these trials that are underway. And the same is true of sort of the brain tumor situation by and large. So, and this is obviously not comprehensive. I only have one slide on this topic, and you could read a whole literature review. So just, at a very high level, a few bullet points. We are obviously very interested in trying to improve outcomes for glioblastoma multiforme. There are some trials that are underway using protons versus photons. The early evidence says there may be some very, very small benefits with using protons versus photons in a way that is interesting, but potentially not practice changing. So this is just sort of based off of abstracts that have been presented at national conferences and some older, smaller studies. So the jury is still out on exactly how that could be useful. Potentially with dose escalation, allowing us to sort of treat things to higher doses with protons, taking advantage of those properties. There are a little more convincing data, I would say, for pediatric brain tumors in terms of long-term cognitive outcomes in certain situations using protons in terms of pediatric medulloblastoma, improved intellectual trajectories. And then more recently, there was a study about pediatric non-germinomatous germ cell tumors that showed improved cognitive outcomes. So that's exciting in that there is an opportunity to do a better job with treatment with this modality. And I mean, we've known this is not news to us. For many of those cases, we've had a practice of referring patients out to proton therapy for a while already. Other evidence is still forthcoming or mixed. One study looked at craniospinal irradiation, which is treating not just the brain but the whole spine, to see if there was a benefit with protons versus photons, and essentially in terms of toxicity. And that's at least not what they found in that study. It seemed to be similar in terms of cytopenia rates. There are many studies that have been published that are not randomized studies, just sort of looking at a cohort to see how patients do. It can be really difficult to interpret those in a head-to-head sort of way because oftentimes patients who get protons are very different from those who do not. And that can make it more difficult to tease apart just how much of an advantage is the protons offering. So the bottom line, which is unsurprising, is that much more research is needed. And specifically, I'm not aware of any really practice-changing clinical trials for meningioma and low-grade glioma regarding protons. So this could be an area for future research. So bottom line, protons do matter in specific situations, and that's why we're so excited to have them in Connecticut. And by and large, they matter in the situations where even small differences in dose can have a real meaningful impact. So that is true when re-irradiating the same part of the body, second or even third time. It's important for pediatric cancers, where we really care about long-term side effects and cognitive development. It's important for when there are sensitive structures that are very close by, such as the brainstem. Sometimes it allows us to avoid those structures and potentially treat to higher doses. Although I guess the caveat with that is it can also be difficult to estimate exactly where the proton dose gets deposited in real life. And so sometimes there's some risk associated with treating something with protons that's right next to a really critical structure. So, and it may be that protons will allow us to dose escalate beyond what we currently can by taking advantage of the decreased normal tissue dose. So this is just one slide kind of summarizing this, X-rays, when we're talking about photons versus protons, we're talking about X-rays versus particles. We're talking about exit dose versus stopping at the tumor. And I haven't touched on this too much, but there are obvious differences in availability and cost. And, it's not, I think it maybe one takeaway is, although it is true, it can be more expensive to get insurance approval for proton therapy. Certainly it's a more difficult to install this equipment and construct it, which is, it takes a real investment. but it's not just that it's straight up better. It does have its advantages and its use cases. And with that, I guess, we're going to continue to hold questions to the end. Okay. Oh, okay, great.
You stay up here. All right. Thank you so much. That was great. We have a little time for questions. Ask away. Yes. Actually.
So the proton treatment. Oh, sorry. With the proton treatment, why is it more difficult, say in the middle of the brain, say near the pituitary, and also meningiomas? Because well, I'm just curious about I guess the protons are very powerful. So does the energy remain in that area for days or just like that?
Yeah, a good question. So the energy gets deposited right away. There's never any residual radioactivity with either of these treatments, unlike other types of radiation, which we won't get into. But I think if maybe what you're asking is, are protons more powerful, and how do we get it? How do we know that it's going to the right place? I mean, we can titrate how much we give to specific places, parts of the body, in much the same way as we do with photons. It's just that the way that radiation gets delivered as it enters into the body is a little bit different. Does that help to answer your question?
I know I like the idea that it stops just past the tumor, and so I get the idea of X beam radiation getting a more diffuse kind of tumor, but a tumor that's say like a meningioma. Seems like it might be a good solution if it gets to the point where it might require some kind of intervention. But I'm just curious if it's eventually gonna make its way to, things like right in the middle of the brain or not.
I see. It certainly has. I don't mean to. Yeah, protons has been tried in all sorts of ways, and it definitely has its uses in treating structures that are sensitive in the middle of the brain. I just didn't highlight that, and kind of the trials that have come out so far are just only in the topics that I've mentioned. And so I'm highlighting that as many patients have been treated with meningiomas using protons. But we may not have a study to definitively say one way or another, is this really better?
I think what you're trying to say is that it's very intriguing to kind of use protons for like central structures inside the brain because of the protection of those nearby structures and like the higher precision that is developed. But as academic clinicians, we want to kind of show proof and the data. So I think what Dr. Moore is saying, right now we're at the stage of calling this a smart idea, but we haven't done the study, or the data is not available to prove to us that it actually is a good idea. And until we have that data, we won't, broadcast it or say, this is what we have to do, because we don't know yet. Is that kind of what you're
I think
thinking?
it's very well said. Yeah.
Okay.
Can you do both at the same time, or have you tried?
That's a really interesting question. I think you could, and I think oftentimes we're using protons in a situation where somebody's had photons first, and then sometime later they need more radiation, and proton seems like the best option at that point. I can't think of a good reason right now why you would necessarily want both at the same time. It would probably make it more difficult to put together a good plan where you really know the dose and where it's going. It's generally easier in our field to make one plan and go off of that instead of using two different modalities on different machines.
I have a question. Can you comment on the folks on your team? And to lead you on, I mean, like the radiation therapists, physicists, like who else is part of your team is the radiation oncology team?
Yeah.
And then I'll also pass to Dr. Moliterno because I know she runs her own professional team. And I think that it's important to know at least all these different team structures here.
Definitely. No, it's definitely a team sport at the brain tumor center level, but also within our department and every one of our clinics. I mean, there's so many different clinicians who are involved in taking care of every one of our patients. As anybody here who has spent time in our department might know, we have radiation therapists who work long days, bringing every patient onto the treatment table and make sure that the radiation is delivered safely and effectively. We have dosimetrists who are involved intimately in the planning of every single radiation plan that we put together and are masters at getting the dose to where we want it to go and avoiding the places we don't want it to go. And there's also medical physicists who are there every day running quality assurance in every plan that gets put together in our department. So these are PhD physicists who did residencies just like doctors do in their own fields. And that's to say nothing of the secretaries and the nurses and the rest of the staff who make our clinics operate. So it's really a team sport, and it's a privilege to work with so many great people every day.
Yeah.
You know my team, Nick. It's a big team. So of course, I mean, we have clinic like these guys do, but then we also have the OR. And so there's a million people that enable us to do what we do. And so nurses, MAs, APPs, outpatient for the clinics. And then of course, not to mention to make surgery safe, so we usually engage PCPs and specialists, cardiologists, pulmonologists, whatever it is, hematologists. So there's a lot that goes into that. And then the functional MRIs, or more sophisticated MRIs, so neuroradiologists and that sort of stuff. We'll maybe do swallow evaluations pre-op if I have to work near the brainstem or near the swallowing nerve. So we get them involved, neuro-otologists and ear doctors and hearing and balance and all that kind of stuff. So that's all kind of the pre-op to make sure that we're as safe as possible. And then the OR, I have a whole team there. I am fortunate that the same scrub has scrubbed with me for the last 10 years. So we don't even talk. I mean, we do, but we don't have to. He just hands me what I need, and I don't even have to look up from the microscope. He just is there, and it's comforting, and I give him so much credit. But of course, as I've gotten busier, he's trained other people to work with me in other rooms. So we have that. We have the circulating nurses and then neuroanesthesiologists. And especially when I do awake craniotomies like tomorrow, I need a very specialized team for that. Or like today with brainstem surgery, very specialized team. So there's so many layers there. And then MRI techs in the OR. And then the post-op, it's, the neuro ICU and the neurointensivists who I've been texting on my phone about my post-ops. And then our resident team, my fellow, our APP, Jen Picagli, who's on the inpatient side. And then post-op, you guys see my APPs who do a much better job of taking care of wounds than I do. And knock on wood, because of them, we've decreased significantly the infection rate and the amazing attention to detail that they do. So like the list just goes on and on and on. I didn't realize how many people. There's a lot of people.
You want to call out your team? Yes, left to. Okay.
Thanks. Nick Blondin, for those who don't know me, I'm in neuro-oncology. I actually have two teams. I have the New Haven team and the Trumbull team. In those teams, I have practice nurses, two different practice nurses in both teams, coordinators. I also work with research teams. I'm the director of our clinical research team. Dr. Kurz and I are the lead Yale investigators on a number of studies. Thanks for calling out GBM Agile. It's a study. We've enrolled over 100 patients in that study, actually, since 2019. So, Yeah, I'm one of the national, it's fine, whatever. So, then also we have a really impressive basic science research operation here at Yale, and I'm involved in a few different teams. I recruit patients into an MRI research study looking at brain tumor metabolism or energy usage in brain tumors. I'm also involved in an effort looking at spinal fluid in patients with brain metastasis and cancer that spreads into spinal fluid. So we're trying to make breakthroughs on like why does that happen and what treatments can we give to folks like that. We're hopeful that actually the proton is going to be an important part of that. So I just think it's important to know we have these big teams, and being team players is cool. So we're all kind of on the physician level, but there's like all these different teams. And then most importantly, I view myself as a partner of everyone going through all treatments. Like for my patients, I'm on their team. And I think that it's important for everyone to go through something like a brain tumor journey. They have their team, their family and friends, their social team, and also their medical team. And it's an honor and a privilege for me to be on the medical team and help try to manage things the best way that I can for folks, and then lean on all my colleagues also to bring in all the expertise. So you never want to go through a brain tumor journey alone, and you don't. You're with your team. So I think that's an important thing to keep in mind.
Thank you so much. Okay. Yes, we can then start. If we're all up for it, we can maybe just start. We have a patient and caregiver panel planned. So Dr. Blondin will kind of just talk a little bit about, I think I just want to kind of set the theme is we really want to know from you what you are struggling with, and what do you need help with, and where did you find help? And we hope that we can learn from each other how we can navigate this journey the best way. So on the panel we have yes. Oh yes. See, I'm blind already. Did you have a question? Yes. Oh gosh, please.
Hi, everyone. So my sister to my right is a major survivor of 3 brain tumors. She hates me right now. No, I don't. One of the things that I've noticed is everything that happens at the hospital or clinician level is wonderful. Y'all are experts. You all are teams. But when the patient leaves that environment, there's very little resource for that patient. And it rides solely on the family. And that is often the case if you have cancer, or you have terminal illness, usually it's the family. But there aren't real resources being given to the family members that call for information that they can go to for their family member. So I hope you don't hate me, but that's my biggest complaint is the patient leaves this cozy little environment and there's nothing out there. There's no resources. So I think maybe we want to concentrate on that as a clinician or whomever, to get that information to that patient, to that family, and check on the patient every so often, see how they're doing.
Thanks so much for this comment. I just want to kind of echo that. I think that is exactly why we're having this event today, because we do recognize there's like the safe, protected area in the hospital and everything is taken care of. But when you're on your own, things are not as easy. So I think, just speaking about the CT brain tumor lines again, I think the goal here is to kind of be a resource to families in need. And it's, maybe less about treatment X or Y or Z or clinical trials, but more about like, how do I manage the day every day, right? Like when your loved one needs care, but you need to go to work and, kids need to go to school or what have you. So yeah, hopefully we can have a conversation about that. Maybe.
So, hi everyone. My name is Chris Cusano. I'm the CEO of the Connecticut Brain Tumor Alliance. I'm an 18-year brain tumor survivor. Was treated here at Yale, and my life has changed. And I'll say it's changed for the better. So, thanks to the team here. But to answer, that point, that is why the CT Brain Tumor Alliance is in existence in what we do. We are here to support the patients and their families through this journey, so that they don't have to go through it alone. None of us are doctors. We're not nurses, but we are all people who have either gone through brain tumor surgery or have supported a loved one or a family member through brain tumor surgery. So, reach out to us. So if you go to our website, ctbta.org, the first thing you'll see are two buttons. It says, "I am a patient" or "I am a caregiver." And when you click on one of those two buttons, there's a field, and you can populate your information, and emails will come to us, and one of us will reach out to you. So in your case, I don't know if you, as the caregiver, or for the patient, or if you want to complete both. But somebody is there for you, and that's the sole reason that we're in existence, to let you know that you're not going through this journey alone, that we're here to support you. Our lives have all changed. We've all been touched by this, and nobody should have to go through this journey alone.
I would like to say something as well. You're right. Sometimes when the patient gets discharged or is done, I don't see them anymore as frequently as I should. I'm Stefania. I'm the social worker. I'm sorry. I do try to emphasize that we have support groups, and not just for brain tumors, but also for caregivers, for example. So we do have that. I try to follow up as much as I can, and I hear you, and I feel what you're saying. And sometimes I feel that I lack of that follow up, and I try not to promise to call you but sometimes I just don't have the time. That's not an excuse. And I apologize on that. But we do have support groups that I would like you to encourage to come, not just for you, for your sister, but also for yourself. And just connect with other people and hear them, their story as well. But you're right about that. And I want to be there more, and I will try to be. That was a great comment and a great wake-up call for me as well, as a clinician as well. Hi, Melissa. Oh, thank you. Thank you. Oh, I'm sorry. No, you keep it. Thank you, Melissa. I appreciate that. Thank you.
So I know over the last 3 years, we've really tried to develop an inpatient neuro-oncology team and a transitional group, really with that expertise, like knowing what folks go through and kind of the shock of their initial diagnosis and recovering from surgery. Dr. Barden has really been instrumental in building our program. I know she has even more plans on how to make things better, but I thought maybe you can just make some comments on, what the work you've been doing with our team and your thoughts on that.
Yeah, no, and I'm glad I have Jen here with me too, because she's another integral part to developing our inpatient offerings in neuro-oncology. I don't want to say that some of you have had this experience. I hope that you haven't, but we know that it's that initial diagnosis, right? And you're presenting to the hospital for the first time with your symptoms. You're being told that you have a tumor. You're having the surgery comes soon. It's a lot to process, and it happens really fast. And then the next thing you know, you're being discharged, and you say, "Okay, here's your appointment with the oncologist," and then you're sort of just in this void of what happens next. And we saw that, and we didn't like it either. And so that's one of the things that we really aim to do. One of our jobs as the inpatient team
is to make sure that to the best of our ability, that first part goes as smoothly and you're as well supported as possible. So you're not just meeting the neurosurgeon, but you're meeting a neuro-oncologist who can help put everything into perspective, that can see you right after the surgery and sort of help you understand what the next steps are. That's Jen Picagli has joined our team as the inpatient APP, who has been super helpful, and I couldn't be two places at once, and so this is as close to it as I get, is having Jen with me. You really are. You're my better half probably, but yeah, also that. But so it's for the new diagnoses, but then I also hope you haven't had the experience of having to come back into the hospital for some reason. But if you have, right, a seizure or pneumonia, blood clot, anything like that that brings you back into the hospital, sometimes that can be isolating too, because you have all this history. You have these doctors that know you really well, but now you're on some medicine service somewhere in the hospital. I shouldn't say some medicine service. They're excellent doctors, right? But they're not your doctors. And so that's where we felt like there was a need too, right? We provide perspective, we provide context for what you've been going through, and we can help the primary team taking care of you in the hospital, whoever that is, to navigate this phase of care, whatever that may be. The other complication of it, right, towards the end of life, sometimes people will end up back in the hospital. And just like I can't clone myself, sometimes your oncologist can't either, right? Or we can't clone each other yet. But having somebody from neuro-oncology there to kind of help navigate those conversations, those difficult discussions and making decisions towards the end of life, or even just some of the difficult hiccups along the way. We really wanted to help fill that gap. And so that's what I've been trying to do. And we're growing it. I think that we have Jen now as part of the team. The hospital system is growing, and with that, the inpatient activities. So they think there's more to come there. But yeah, our goal is to kind of make that aspect of your care better. And I hope that we've been able to do that so far.
I know, Jen, you bring some unique perspectives to your role in our Brain Tumor Center. If you want to comment.
Sure. So my name's Jen Picagli. If you have been in the hospital in the last year and 3 months, I may have met you. If you were in the hospital before that, I have not met you, which is good. Because I only work inpatient. I work as a liaison between the oncology team and the neurosurgery team. And part of what I try to do is get things to be smooth as I can. And one thing I hear you say, that what happens after discharge. One of the things I've been actively working on is I hand out a sheet when I see folks after surgery that is one page, just one page. That's it. Not too much. And it says, you just had brain surgery. And on one side, I have resources. I have the American Brain Tumor Association with a link to information, which will be helpful because at the time you leave, you may not know the exact type of tumor you have, which is terrifying and frightening. You're like, I just had this thing. I don't have a name for it yet. But I tried to provide a link to a well-resourced place that you can look it up. The other thing I've done is I've put a link directly to the CTBTA on there, because I've heard from folks that they need some other resources. They need things day to day. And I've given people a sort of a list of little hints that I've heard. Things like, you might get dizzy if you bend over. Or that first week might be a little blurry if you've never had anesthesia before and you don't know how you're going to react. To things like, yeah, remember, don't pick up anything too heavy. You want this to heal up well. And when I'm able to, which is, I would say more often than not, I try to really just sit with folks and their families, often the day of discharge or before, and sort of go through what questions folks have. I joke sometimes my job is translator, that I translate from science or something that you were told at 5:30 in the morning to it's 2 p.m. and you've had lunch now, so we can maybe get through this again. And knowing that anything we tell you, you're going to have to hear it again, because all you heard in that maybe 5-day, maybe 4-day period is something like, and this is a common story, you had a seizure, we did a picture, You have a tumor. We're taking it out now. See you in a few days. And that's common enough. And that's a big, huge, scary change for folks. So if possible, I want to try to make that a little more human for folks and make your follow-up easier.
Thank you, Jen. So I want to introduce Mr. Paris, who is a patient of ours, and maybe you want to just share a little bit about how your hospital experience was, maybe when you kind of came in and the world turned upside down.
Yes, it was a very difficult process for me. I ended up having a seizure, pretty unexpected, watching my nephew's basketball game, probably in front of about 100 other people. So that was pretty scary when that happened. I ended up going to a hospital in Springfield where I was diagnosed with an oligodendroglioma. At that point, I wasn't really quite sure who to have actually provide the surgery. So I did a lot of research, and that's how I found Dr. Moliterno, and Dr. Kurz has been great, and everybody else on the team here has been so amazing. I love everybody that works here. They have been so good to me. So I really, really do appreciate that. And I'm actually on Voranigo, one of the newer medications, and that has been working really, really well for me. I don't have any bad side effects from it. I feel pretty good. I'm also on Keppra to prevent future seizures from happening as well, and that seems to be working great also. So, yeah.
Do you want to comment, Chris, on just what you remember about that day and that time, and then kind of like what you've learned since then? Sure. And probably, if you have common things you've heard from folks through your CTBTA work.
Yeah, I mean, so the day that I was brought in, my surgeon looked at me, and I think he knew that instantly what the diagnosis was, but they sent me for a neuro-ophthalmologist, and within days I got a phone call telling me to come back to the hospital. They delivered the diagnosis to me, and unlike some patients that I've heard of, I didn't have time to go home and process it. I was told you're having surgery tomorrow. I'm not really sure how. The medical team was astonished by how it was functioning because based on the presentation of the MRI, they thought the tumor was probably there for 3 to 6 years, possibly longer. So about a 3-hour surgery turned into a 9-hour surgery the first day, and then I was in the ICU for 2 weeks, and I developed an infection, and then I had hydrocephalus, so I had required a shunt, and then a shunt revision, and then my tumor was atypical, so it did it was regrowth. So we tried gamma knife radiosurgery, and then that unfortunately did not work as expected, so required a fifth surgery as well. So I've been through it all. I've seen it all over the course of from 2008 through 2016, and I've seen a lot, and I've learned a lot, and I've absorbed a lot. But I've also seen my family and what it's done to them, and so I'm very grateful for the support that they provided to me, and again to the medical team of doctors that have continuously stood by me and supported me, from the surgeons to the nurses to the neuropsychologists to the PT and OT therapists. It does take a village, so it is multidisciplinary. And it's just the way that you all work together, really it's very powerful and reassuring for the patient and their family.
Are there any common questions that you can think of that folks ask you, or also do people reach out towards the beginning, just after a diagnosis, or after a while? What
depends.
happens?
We hear from patients at all various stages. So right when they're diagnosed, they're kind of processing the information, wanting to know what do I expect? I'm having surgery. Am I going to remember everybody? Am I going to remember names, faces? And then there's some who have gone through this, and then they're in recurrence, and they're reaching out just for support, to talk to someone that's been in their shoes, that has had a recurrence, or caregivers. So I mean, there's a lot of caregivers that want to connect with another caregiver. And on our board, we have many caregivers available that are willing and able to always share and be there for that somebody else.
Yeah, I agree. And for my practice, I've seen a lot of patients that do make connections through CTBTA, and they find it very helpful. And so just knowing someone else who's gone through something similar, or folks that feel like they learned a lot from the journey that their loved one went through or that they're going through, and they want to share that
I mean,
information with
one
others.
of the common things we hear is, people say they learn of their diagnosis and they just want to talk to someone else that has a brain tumor diagnosis or has gone through this. And just to have that initial conversation, I'm always told how reassuring and like, thank you. Like it's, because until you're in that moment, you don't realize the gravity of what you're about to face.
Yeah, I think can be hard, and it can be okay to not really be ready, like mentally, to engage in groups like that. But they're there. They're there when you're ready. And so CTBTA is an important group, and then also our Yale support groups are also really a great resource for folks. I know Stefania, you commented on that, but if you want to just talk a little more about what those programs are for folks. Yeah. For our group or in CTBTA? Yeah.
Yeah, our groups.
I just want to say thank you, Yale. They are just really appreciate the patient. But I do have a question. It did not happen. Did not happen to me, but I did hear that there was a patient who wanted to go to Yale, was picked up by an ambulance, and because they were near two hospitals that it had a certain level, they had to go to one of those two hospitals and not go to Yale.
Can you comment on Dr. Moliterno? She has something she's been working on for over a decade to try to overcome these various kind of barriers.
Yeah, just call my cell phone. It's basically no, but I can tell you from like any part of the world that I've ever been in, traveling or whatever, every time, whether I'm here, there, wherever, I always get these calls, and I can like picture where I'm standing at various places, and it's the same story. So it's horrible. What I'm just going to be honest, I won't name, but it's horrible what some of these other hospitals do, because your revenue, right? Like your money for surgery, your money for chemo, your money for radiation. So a case is a case is a case. And so at these other hospitals, that's why I was saying, don't feel that you have to rush into surgery, because I hear what other surgeons say to kind of rush other patients into surgery. And it's just so wrong. I've been on the phone so many times where patients are sitting in hospital beds at other places throughout the state, and they know somebody who knows somebody who knows somebody who knows me or Chris or somebody. So somebody texts me and I say, no, we got it. And then we have a whole mechanism to deal with this. And we have funds, thanks to CTBTA and others, that can even pay for ambulances, because what they will do is they double down and they will say at the outside hospital, it's against medical advice if you leave. So then you get stuck with the insurance bill. And we have ways to challenge that and to deal with that. It's really disgusting what these people do. And I've seen it, and I know who the culprits are. So all I would say is for CTBTA and for anybody here, anybody who can talk to anybody, just let everybody know if they want to come here, they can get here. And so there's an Y-axis number that they can go through. A lot of times those physicians at the outside hospitals will refuse to call it, and then they threaten, and they'll say, well, it's not covered by insurance. It's not this, it's not that. And that's all BS, frankly, because we do it all the time. But there are like hoops we have to jump, but we know how to jump them. So, and all joking aside, I mean, I answer my email no matter where I am, jennifer.moliterno@yale.edu, and I will be on it as fast as you can say. But I'm sorry, because it's terrible. Took over your moderating.
In the morning, and at 6:10, she said, "I'm happy." She said, "I'm happy to. I'm sorry about Peter, but I'm happy to have him come to Yale, and I'll have my Kelly or whatever her name was arrange it." But they didn't want to let him go from the hospital.
The other thing I'll tell you, which is really kind of like appalling as well. So, for instance, one of the patients I'm operating on tomorrow was operated at another hospital in Connecticut. The surgeon there did a biopsy, right? Tomorrow, I'm going to do an awake craniotomy and remove it. So that's a much bigger, in-depth procedure. The reimbursement is going to be the same. And I don't get it, like at the hospital, whatever, probably same for that guy as well. But the point is that what these other guys do, and we know it, is that they do a little bit more than a biopsy, but it's still a biopsy. And I showed you all those scans where the pre-op looks like the post-op, but they charge and bill the same amount as I do for the big operation. So I'm serious, like we see it happen all the time, and it's just disgraceful. And so I can't tell you how many people I've reoperated on who have infections because of their first surgery. And so now I have to deal with the infection and then remove the tumor. And then, that sets them back from radiation. I mean, there's just a lot of stuff that goes on out there because unfortunately, there are people who don't think of the patients, even though they're doctors. And not all doctors are created equally. Not all surgeons are created equally. And some people have the skill set and some people don't. And it's that simple. So,
thank you.
So email me.
My husband and I were also victims, I'm going to call it, of another hospital, which I won't name, in Connecticut. But we actually had not a biopsy. Chris had a surgery, which turned into a biopsy, but it was a full surgery. So luckily we were blessed and we came to Yale, and Dr. Moliterno, of course, saved Chris's life, did the surgery. Dr. Blondin is taking wonderful care of him, and Dr. Moore, of course, with radiation. But what I wanted to say is that we were able to compare the care that we had at that hospital, the process, all the steps that we were giving, everything. We had a meeting with radiologists, with oncologists at that hospital as well. And when we came to Yale, 2 weeks later, Chris had the surgery that saved his life, and he's working. He's a month and a half back to work now. But the whole process, you have such a powerful system and amazing doctors and amazing care. And at the end of that, we're really grateful to be connected to actually Chris Cusano and to Brain Tumor Association, because that actually led us to meet other people that are in the same situation as us. And it's up to us, honestly, to take that next step. But we'll be forever grateful. And Chris wants to talk.
I was wondering if I could ask a question that's totally off topic.
Yes.
Today, when I went to work, there's a girl that works with me. She's Puerto Rican and she has family in Puerto Rico. And she basically mentioned that one of her relatives has glioblastoma, just like I had. The only thing is they weren't able to do anything with it, but they won't allow him to travel. Is there anything that could be done for something like that? Or they just basically said that, well, there's nothing we can do for it. And of course, money, I'm sure, is involved. But yeah, is there any way to bypass that system and just basically get him here and get a second opinion and all that?
We have systems for everything. So yes, I mean, there's logistics, and I mean, Dr. Kurz, everyone will talk about how we are always getting requests for opinions internationally. I mean, beyond Puerto Rico, all over, frankly. And so there's some logistics with that. We do have some funds to help with that. So all joking aside, I'm happy if you put me in touch with them, happy to see. Sometimes we can be limited, but sometimes we can also, I mean, we do it pro bono all the time, just review the films, review the diagnosis, and just kind of give our opinion. And that can be enough if we think that the care is reasonable where they're being treated.
Yeah, I mean, just to put some perspective, if they kind of don't allow the traveling, I think what might be going through their heads is that, if the tumor is sizable and there is concern for increased intracranial pressure, and then you kind of think about air travel, like what might that shifting do? And might you, by causing those shifts to happen, threaten this patient's life? And, to be honest, that's a judgment call, right? Like we would have to kind of look at the films and make our own judgment. And they may have judged their way. Not traveling is always the safest thing to do. And then, from us, kind of from outside, it's becoming a liability issue, right? Like we haven't seen the patient, we haven't evaluated the patient. So are we really kind of firm in making that call it's safe to travel or not? Can sometimes be difficult. But I think I remember patients that needed to travel. Like I do, just to tell the story, I do remember there was a girl in Israel who wanted to participate in a clinical trial that I was enrolling patients to, and those surgeons also hadn't allowed to travel because the tumor was so sizable. And then actually we kind of discussed with that team, and then the neurosurgeons there didn't fully resect the tumor, but they kind of resected as much as they dared. And then the patient was safe after that surgery to kind of travel and participate in this clinical trial. So actually, this was one of the patients that I enrolled on this study with the K27M mutation. And she responded to treatment, and it was certainly kind of important for her. But what I'm trying to point out is that we can collaborate, and we're trying to help as much as we can. And sometimes it does require effort to get the best plan for the patient.
Yeah, we do. We review cases like that at our Friday tumor board conferences. Dr. Moliterno frequently brings up cases like, well, let me show you guys this, or what do you think about this situation? Yeah, and it's just, it's helpful. And then we lean on each other to know what the right thing is to do for someone. And I feel proud of our institution that we really are in this just for the patient. It's a privilege to work at Yale, but it's really a bigger privilege just to take care of folks with brain tumors. And yeah, it feels good that there's no conflict of interest, but on my part or on any of my colleagues' parts on any of this, we want to just do the best things for people. And it's nice. It's a real key to our big program here.
I have a question for the group, maybe. I mean, we're all sitting here and we're learning all those things, and it seems like, we're in the right place right now. But can someone share maybe like, how did you find out about Yale or CTB, Brain Tumor Alliance, or any of that, or would you have loved to kind of learn sooner, later, differently? Okay.
My name's Christine, and my youngest child has a astrocytoma, and my husband Patrick is here with me. My child was vacationing in Florida, living in Florida, and Dr. Aziz Shah in Miami reached out to you, Dr. Blondin, and he said, I have this child from Connecticut, and you said, get her here. And that's what we did for Yale. I mean, we weren't really sure. We were thankful to be here and living here. But yeah, from Miami, they took out the tumor the best they possibly could. And then we arrived here on a Saturday, and we were in Dr. Kurz's hands on a Monday morning. And I will speak from that point too, that for us, and you were very helpful for social work. Our first appointment was 3 hours. And I can remember it just like we left there and we met a lot of people, and she's 23 at the time. But I remember thinking, if they can spend 3 hours with our entire family to address and to move forward, I'm like, I have a whole new appreciation for oncology and the staff for that reason. Because when we go to the appointment, and maybe it's late, maybe it's not, I'm thinking to myself, 3 hours. We never felt rushed. You answered all of our questions, and we met neurosurgeon teams. But how we ended up at Yale was somebody who he met you at a conference, and
Nice.
that's what he said. He reached out and he says, I've got to, so for us, Florida got us here.
Yeah, I want to say like one reason why I'm really liking to be in this field is that, we have a great family here, but neuro-oncology is actually well connected all over the country. So we have friends everywhere.
So in 2011, I had a seizure. I went to Atlantic City for a weekend of concerts. And luckily, I was in a room with my friend who noticed this seizure. And I woke up with probably 7 or 8 people like right in front of my bed with this gurney. And they said, you've been having a seizure. You need to go to the hospital. And first, I didn't believe them, but then I let them take me. Went through the lobby of the of the casino, and there I am in the ER of the Atlantic City Hospital. And so CAT scan, then MRI. Then the Dr. Stenger, I think he was the neurosurgeon on call at that hospital, asked where I was from. I said, oh, Connecticut, New Haven area. He says, oh, I have just the guy for you, Dr. Joseph Piepmeyer. And so he gave me his information, put a call into him. And 3 weeks later, after an active MRI to make sure that my language hadn't migrated to my right side, because I have a right temporal tumor. And so, yeah, 3 weeks later, I had it was a brand new operating room with the 2 suites at that time. And so it was a 6.5-hour surgery. And I got out the next day. So hooray. I got out of Dodge. But so Yale's good reputation is known far and wide. And so thank you. And
thank you.
Dr. Blondin, thank you. Yes.
So we actually, when we were at that other hospital, the sad part is that none of the doctors referred us to Yale. That actually we insisted to be transferred to Yale, but we only found out about Dr. Moliterno and Yale through a friend of ours, because we were doing charitable work through Lions organization, and someone knew that Chris was sick, and then another person reached out, and another person reached out, and he says, I had a surgery, please call Kelly, and that's how we were connected. So it was a true blessing for us. But the sad thing is that we were not referred.
Good evening. I just wanted to change the subject a little bit. I got diagnosed and had surgery with Dr. Moliterno in October, and I'm now wearing Optune, which I know has not been mentioned, but it's doable. It's actually really doable. The question I have is that since I got diagnosed, the algorithm has my number and picture on it. So I am bombarded constantly with all kinds of information about cancer treatment, about supplements, and so I guess my question is, where do I go with some of that? I'm a doctoral level psychologist, and I'm overwhelmed with all of the information out there constantly. And, and I know, the traditional NOs have I want to say they operate within the box, but Dr. Kurz and we've talked about that quite a bit. But at the same time, I think it would be very valuable, and maybe it's out there somewhere, but where do you sort the wheat from the chaff, so to speak, about what are viable, what are maybe possible kinds of other alternatives versus what's total garbage and should be dismissed? And so that I just found it over the last 7 months overwhelming, the amount of information that gets thrown at you on a daily basis.
That is a great question, something I get pretty much every day in the clinic. My advice, I guess, just overall would be to talk with your doctor, your provider, to get their take. So as physicians, one of the rules of medicine is first do no harm. Make sure that if someone is going to pursue alternative treatments, that it's very low possibility of making things worse for them or causing damage. And that means both medical and also just for their life in total. Some supplements or alternative treatments are extremely expensive, and that can really, be a negative for someone's quality of life and their family. So we're trained in conventional treatments, chemotherapy, tumor treating fields, obviously surgery and radiation techniques. But there is a lot of lab evidence supporting use of certain alternative medicine strategies, certain dietary strategies. And it's really difficult to run clinical trials in a scientific way to prove or disprove certain therapies. So again, it's just important for you to talk with your doctor, because they'll know your overall medical situation, other medications you may be on, or what could be safe to try.
usually in combination with standard treatments.
I want to echo what you just said. I think the other thing I just want to say is that, kind of the first step probably is, kind of build that trust in your medical team. So, in terms of, I think as long as you're not doing less than radiation or less what we discussed, like you're not missing out on a big treatment or a big cure or like something big, right? So I think with all the overwhelming information that people are flooded now through social media, internet, email, newsletter, cell phones, calls, whatever, I don't think any of those things in general are kind of the big breakthrough or that will bring you like the big difference. And then, the second step is like the nuanced treatments. Maybe it will add a little bit. Maybe it will help. Maybe it will help with quality of life. Maybe it will help you psychologically that there's something else you can do. And then, you navigate the information that's thrown at you. And some things may intrigue you more than others. And then I always invite all patients to kind of bring those up to me so that we can have a discussion about it. And some things I do know stuff about, and I can put things into perspective or explain things why or why not. This might be a good idea. And other things I don't know. And then we'll kind of learn together and maybe we'll make a decision together about that, right? So I think this is just another example where we want to be partners with you and we don't want to I always say to patients, I rather want you to kind of bring up something that sounds silly to you, and we can have a discussion about it, rather than you trying to figure this out on your own and worry about it, and I may not know what you're taking.
I learned from, I think her name was Natalie. She's one of the dietitians. But for example, that at Yale there is the pharmacy team. And it sounded like, wow, that's a great resource. I mean, that you can actually do a consult with the pharmacy team. So I didn't know if there was something like that for like outside of the normal pharmaceutical recommendation, but it was just an idea of, just vetting some of these things. I can't call Dr. Kurz every time I think of something, so that's not going to work. But like kind of like this pharmacy team, if they're just some forum to address some of these kinds of issues because it's overwhelming.
Thank you for that comment.
Don't ever ask for stories when I'm in the room because I can tell them all night. It was interesting just, getting to Yale because my primary care physician, my oncologist is up there behind the podium. My surgeon is looking at her email down there in the corner. And I was a test pilot at Sikorsky, and every several years we have to go through Dunker egress training out in Groton. And one of my biggest symptoms kind of manifested myself at the school. And the schoolhouse said, okay, here's this medical form. Go to your primary care guy. If he says you're good, we'll put you in the pool. And that conversation didn't go very well. So I had to spill the beans with him, what was going on, all my symptoms. I took a CAT scan. He called me at home an hour later, told me to get to Bridgeport Hospital. They're waiting for you. And I believe you were one of them, along with Dr. Zimmerman, when I showed up at Bridgeport Hospital. And the next day I was in surgery, getting a shunt put in. And then had some continuation of issues going on, new symptoms. And kind of like in the movies, Dr. Blondin wrote a bunch of names down on a piece of paper, slid them across the table, and said, we got to make a move here. And called several doctors, Jen, one of them, and she won. And she did the resection of the surgery. And then comes the CBTA part. I think it was one of my visits to you. And you said, hey, I'm going to put you in for this Courage Award with the organization, which I immediately refused to take because I didn't do anything. I got sick, laid in bed on drugs. You're the hero. You're the hero, not me, right? But that's where I got to meet Chris and some of the people in that organization, which has been a real blessing. And the Yale support groups. In some weird egotistical way, getting an award and stuff. I thought it was suggested that I go to that. or as many as I can because your meeting is right during work. But, maybe I can help other people. It took me 10 minutes in that thing to realize I needed it. So thank you. That's it. I'm going to start crying. Yep.
Thank you for sharing.
Thanks for sharing your story. I know it's powerful, and recovery and it's everything. And so in this line of work, I love partnering with people to help guide their treatment, determine with them together what's the best treatment for them, and hopefully get the best quality of life that a person could have going through a brain tumor journey. And it's different for every patient.
I just wanted to say one more thing since you brought that up, and kind of to what the woman said first. From the moment I got into this system, I never once felt like a number. Never.
Good.
I felt like Joe. And I felt like I was truly treated that way, both by you and Jen and everybody else I came in contact with, right? And thank you for that. It's been a wonderful shitty experience. How's that sound? That makes sense?
Yep. This has been a really great program. I know it's getting past like 7:30 now. I don't know, Jen, if you want to make any final comments on this to wrap this up, but I really appreciate everyone sharing their stories. It's great to see a lot of faces I know in the crowd here, and we'll keep it up for you. We're trying really hard, and we're going to get that breakthrough for all brain tumor therapies that's happening.
Can I make one final comment too? Is that okay?
Mary Barden.
Yeah, so I just thank you, all of you for coming and for sharing your stories. And we talked a lot tonight about the things that we do and we try to do. And I want to promise to you that we don't rest on our laurels here. A lot of you said really nice things, and we like to hear nice things, but we don't say we call it a day because we made these people happy, right? We don't rest on our laurels. We're constantly trying to improve ourselves here. We're kind of weirdly obsessed with it. On the inpatient side and surgery, like we're kind of crazy about it, Jen, right? Like we're a little bit insane about how much we want to make things better for you. And we're not perfect. And some of you might be sitting here hearing about one person's great experience and being like, man, that's not how it happened for me. And that we want to hear that too, because we can't make ourselves better if you don't tell us the tough stuff too. And so thank you for being here. Thank you for sharing everything that you did. And if any other comments you have, text Jen or send us an email or let us know, because it's as you nicely put, right? It's a shitty experience, and we wanted to make it as least like that as possible.
I think just the one thing to follow up with that, as I was listening to the first comment, I think that, sometimes, and I don't even want to say that, I think we fall short, of course. And I think sometimes, I hate to say this too, that we're human ourselves, right? And like there really are, I hate to say this as well, only so many hours in the day, right? And there's so many people. And even, don't tell anyone I said this, like we get tired at times too, right? And like, it also affects us. Like it's not easy. I mean, everybody we know has a brain tumor. Everybody we know is going through shitty experiences. Like it gets to us as well. So I think that thanks for sticking with us and bearing with us. And we really try our hardest, but we just try to do our best. And it's just an honor to take care of all of you. So text me. Sylvia?
Well, thank you very much for coming. I think I can echo just a few things. So, we want to hear from you, and what resonated with me was what said over there, right? That somehow there is like still some component of support missing. So if you feel like you need more of these events, you need more, phone numbers to text or other contact information to have, bring it on to me, and we can try to make things better.